Okay. Okay. So first I'd like to talk about a part of the course that is course resources. It's down below week 4 in the Canvas shell. And there are a number of documents that would be useful, especially in the in doing your LRA, history of the Health Reform Act, Supreme Court acts, summary, and some other discussions here that you may find useful. So the these are all, for the most part, if we take a look at like the first one, the history of the Healthcare Reform Act, is actually something that comes out of an article in the New York Times, for instance. And it's a timeline. So there are several links in there. It's not coming up for you. Ah, that's the right thing, except that you should have more information there. Let me show you what's here on mine. It sure isn't. No.
Oh, you know what?
Oh, it's still loading?
Oh my God.
Okay, good.
Wow.
Well, maybe,
Let me do it.
yeah, might try that. But if you use this as a source, the thing to remember always is that when when you use this as a source, you identify the newspaper article. But if you can find further information, it's always a good idea. Newspaper articles. We like to think our newspapers are pretty reasonable as sources, and they can be for, just reporting general events. But you have to be kind of careful when you try to use them as primary sources for controversial information. And they have a checkered history, unfortunately. I do believe that we need to use newspapers, and we do, and they're useful, but you should be using newspapers as much as a guide as it is as anything else. It's hard sometimes to get other information because, of course, the only other thing would be something extremely, almost useless, like the congressional record. So, but again, if you can find other sources, 2, I think, 2 or 3. I think 3. I think I wanted 3. Yeah. Okay. So these are outside outside sources that are providing this, and so these links should help provide a certain amount of. Hello, Katie.
Was in your class this morning.
Yes.
Yeah, if you could please keep an eye on her this March because we didn't pass last March.
Oh.
And yeah, we are heading for SAT if we don't pass this class.
All right, I
Month,
will.
So just, yeah, be on her.
I will. Yeah, and work.
And work, lots of things.
Work.
Thank you.
Yes. Okay, I will do that, Katie. Okay. So, so there is some there's a number of topics that we have in this mod that you can use for part of your research. You know, that's obviously. Why don't we just take a look at it? It is something that was part of trying to get people to get into the the various aspects of the Affordable Care Act. And it was an interesting bit of organization for people who were trying to get people to make use of a variety of ways to take advantage of changes in medical care. Some of this was run through the Center for Medicaid and Medicare Services. Others were more privately operated. And the Affordable Care organization sort of trying to help with coordinating care for various Medicare beneficiaries who are not able or don't understand how to get the benefit of their programs. It was an interesting set of events that led to how these were received and how they were able to help people. It's an interesting article. So, all right, well, let me just make one quick check here. Okay. All right. So looking at what's going on just this week, we also have an assignment here, which is a terminology assignment. I just wanted to bring that up. Really, I want you to basically define these terms and submit that as a text entry or a document entry. Should be readily available that way. There's about 20 terms here. That shouldn't be a major issue for you. And then there's a quiz this week as well. So let's go back and now go back to talk about the, see if I can find it. Nope. Nope. We'll have to. We'll do a new share here. And all right, That should do it. All right. We move forward now from our sort of historical look at the development of healthcare in the United States. Go on to what's been going on starting in the 1980s, when the Reagan administration was trying to reduce the government's involvement and expenditures in a variety of different programs other than defense. So they tried a number of things. They tried block grants to states for instead of funding various programs and let the states determine what they were going to do with them. They were reducing as much as they could social programs. This is when we started hearing people raving about things like that they call welfare queens and so forth. Mm-hmm. A lot of fictions that were used to punish a broad swath of people for the sins of a few. The prospective payment system known as the diagnostic related groups came in for handling hospital payments. We know that there were a lot of problems with DRGs. We still deal with them in a number of ways, but they put this together in another way to try and save federal dollars. The problem is it didn't actually reduce the cost of medical care in the country because they really didn't put broad controls on the vendors and on suppliers, and so it didn't seem to help. The expenditures for various things had more to do with overusage of medical procedures. We talked about technology as a tyrannical source last class, but we had a lot of different things happening. We saw huge advances in medicine. Advances in medicine are wonderful for the patients, but they're horrible for the budget. We developed we've developed improved polio vaccines, whole series of drugs, the minor tranquilizers, Valium, Librium, etc., started appearing in the 60s and 70s and really had a tremendous impact on cost of medical care. CT scans and MRIs and heart-lung machines, birth control, all sorts of things were coming along at that time that added to the cost. With every technical advance, there are unintended problems that come with them, unexpected problems. We found we early in the first part of the 20th century, we really started developing tremendous means of extending human life, largely by cutting the death rate from childhood diseases. We didn't really start getting into the technologies for extending end of life. Some people naturally lived a long time. My grandfather was, I think he was 87 when he died. Yeah, he was an Irish immigrant, so he had a rough life, worked hard all his life. He lived to be 87. Unfortunately, I only met him one time. That was, actually, that I remember. Mm-hmm. There's some wonderful stories about when my dad was overseas when I was a baby. My dad was actually on Guam when I was born. And my grandfather did some of the care for me. And my mother tells some great stories, told some great stories. But with technology, and of course, doctors, rarely do you find doctors that'll look and say, well, that's a poor person, he can't afford it, so I'm not going to offer this technology. They just do the technology. Mm-hmm. And then people got to pay for it whatever way. Maybe public, maybe not, maybe debt. But the problem is that we started making use of these things without really looking for the benefit to the patient. That should have been our number one goal. If we're going to make use of a technology, we need to know that it's going to benefit the patient. And we started getting lawyers involved, which means that we have all this wonderful technology. What do you mean, doctor, you didn't use this new technology and this person died? Could you have saved them if you'd used it? You know, a lot of emotional crap, and lawyers got into that. And as a result, doctors, out of self-defense, would overuse technology. And part of me can't blame them. You know, who wants to be hauled into court by some lawyer because a patient died and you didn't do everything about it?
And, you know, along the same line as one of the challenges, because they can't, some of them can't keep up with the technology.
Yeah.
And they choose not to because of cost.
Mhm.
They don't antiquated IT equipment, you know.
Yeah.
But like stuff like the medical electronic records, that's mandated. They have to, you know.
Yeah.
So
it puts a financial burden
yeah,
on people because even with electronic health records, all of these things, all of these electronic records, there's no standardized system. Not really.
Really?
We'll get into that when we talk about health information technology next week. But there's no standardized system. They don't communicate. One of the biggest things has been how do we communicate across platforms? And when you have multiple platforms and it's all proprietary programming technology, they're not, you know, talking to them is not going to be, talking across platform is not easy. Then you have HIPAA considerations, you know, so there's a problem there. Yeah, these things get mandated, but again, the unintended consequences are that physicians look at it and say, I can't afford $25,000 for the software and another $25,000 for the equipment to run it. You know, it's just not. It's really kind of it's a difficult situation to be in for sure. So we overuse the technology, and we second guess developments. There was a story about a woman who was premature birth, and standard procedure for premature birth was to put babies on high oxygen to try and get their lungs to yeah, because we didn't have the technology to inflate lungs. Lungs are about the last thing to develop in a fetus. So we didn't have the technology to help inflate their lungs that we do now. So they would put them on oxygen. Well, there was a high risk at that point of the babies ended up from all that oxygen at destroying their optic nerve, and they were blind. So the choice was, you want a blind baby or you want a dead baby? You know, so they would put them on oxygen. Well, that was a risk. It was an unknown risk when this one lady was born, and she got, somewhere or another, they got a lawyer who sued the doctor who delivered her and, you know, basically saved her life, saying that there had been an article published in the Journal of the American Medical Association the week before she was born that said that you shouldn't give oxygen to premature babies because there's a high rate of blindness. So I'm sitting there saying, when I heard that, I thought, well, it's a good thing they don't have me on a jury, because I'd look at him and say, you know, how much time do you think this doctor has to be reading every issue of every medical? You know, so, but they won. They won. The doctor's insurance had to pay, and that's, you know, so skyrocketing insurance. Our first, when we had our first baby, we were going to a general practice in Durham, North Carolina, and they did everything from babies to, you know, to hospice care.
right.
You know, they did it all. By the time we had our second baby, they had dropped the OB side of their business because their malpractice insurance had gone up so high
for people who had OB as part of their practice. They just dropped it to cut their insurance rate, to cut their insurance payment. So they, they were out. We had to go find, we had to be referred to a local OB practice, and the one we ended up with was the first group was horrible. The second group was one of the best group of doctors I've ever dealt with. Yeah. So, we weren't unhappy about it. I mean, in the long run, but it was a tough one. So there's always been an involvement of the federal government in the development of new technology, whether it's new drugs or new devices or anything else. A lot of the research is done using government grants. Not all. Pharmaceutical companies spend billions of dollars a year on drug research, but they also monitor everything that's done at every medical school in the nation. And there's a lot of medical schools that have people working that specifically are looking for cures for disease, and they invent new drugs. And so the pharmaceutical companies buy them up. The way it's structured, the federal government, under the rules established for federal funding, an academic institution or any government grantee has to patent a new discovery and then has to try to license it for development to a US-based company. That's a requirement. So all of these, and they all think they're going to get filthy rich, of course. So some of my worst experiences were dealing with academic inventors. They just thought that well, you're a rich drug company. You can give me $10 million for my drug that I just put in a mouse and it might work. No, I don't think so. We're not in the business of curing mice. So there's a lot of that. But there are a lot of agencies were created by the federal government, and a lot of times in partnership with professional organizations to sort of look and evaluate some of these things and advise the government in approving drugs. The FDA brings in advisory committees of independent medical researchers and physicians to examine the data presented by pharmaceutical companies and advise the FDA as to whether they think the drug should be approved, should not be approved, or should have more research. And these are people who are, by law, they're not associated with the drug industry, so they're pretty much independent and objective in their views. But it's a cost. It's a cost, but it's also, at the same time, a bit of a savings because the FDA doesn't have the personnel to do that on their own. They don't have the budget to hire the people, but they can bring in these agencies. But we have CMS, the government, the Center for Medicare and Medicaid Services, we used to call the Healthcare Financing Administration, HCFA, has a number of arms that do a lot of policy research, and they are involved in things like developing new approaches to medical records. ICD-10 was developed by HCFA and then CMS, and it turns out that my sister-in-law was a project leader. So, that was quite a process. It was a 10-year process. And then nobody wanted to adopt it because they didn't want to have to now switch from 9 to 10. And one of the things that when there was a big push for that, I called up my sister and said, "Look, how can we train our people? Give me some ideas as some resources that we can use for training our students on ICD-10." So she gave me a lot of good ideas, and I passed that on to our people. Yeah. Mm-hmm.
And they, how often are those ICD books updated?
Not very often. I mean, I think they probably go through, and as medical, knowledge increases, they'll be adding things to it. But the idea with ICD-10 was to come up with something that was much more flexible than ICD-9. And it's more, by nature, it's also more confusing. But once you learn it, apparently it's not too bad. The problem is most of the teaching tools are garbage. Yeah. Yeah. But if you are good with that, you're in demand. Yeah. It's going to be one area where there's going to be a lot of demand. And then there's a problem of how do we educate our medical professionals? We have a real variety of things going on. My wife took her PT degree from Northwestern Medical School in Chicago, and we still get their monthly magazine talking about the work that's going on, the research and stuff that's being going on, because Northwestern is a major research institution as well as a hospital and teaching institution. And in fact, most of the medical schools and teaching hospitals also have a lot of research, some of it clinical research for the pharmaceutical industry, but others is independent research under, of course, all the usual permissions from NIH and stuff and the FDA for independent research on diseases that nobody else is interested in. So there's a lot of that goes on, plus a lot of basic research. I usually take a look at the Northwestern magazine because they've got some interesting stuff going. But they also train not just physicians. They have a nursing school. They have the school of physical therapy, of occupational therapy, and all sorts of things. So these are, as we learn more and as we develop better technologies, we have to educate our doctors. And the problem is, once you get out of medical school, yes, you're supposed to do your continuing ed. You're supposed to go to your medical society meetings, the AMA meetings, and if you have a specific interest, cardiology or oncology, you go to the American Heart Association and the clinical oncology meetings, and others as well. I mean, psychiatry is another one. But medical knowledge is, a few years ago, medical knowledge was doubling every 2 years. How do you keep up with that? It's not possible. Yeah. So medical education is it's not that a doctor gets out of medical school and gets finished with his internships and all those other things that he does or she does to get started. But then she has to keep up with all the new developments. And that's hard to do because then you also need to see, under our current model, you need to see X number of patients a day. The only people who don't have to do that are the high-level surgeons who, they don't rush surgeries. Oh, I've got 5 hips to replace today, so I better get busy. No, it doesn't work that way. Yeah. Remember, they called it Hillary Care. It was an attempt that ended up looking to some extent like the Affordable Health Care Act that finally got passed under Barack Obama. But it was an attempt to really give universal health care to Americans. And it was vilified. And this is what annoyed me. Nobody looked at the merits of it. They just vilified it and called it Hillary Care and Billary and Care and all that other stuff, and refused to consider it because it was not part of their plan. And the medical professions were largely against it too, because it would have changed the face of medicine in a lot of ways. But the failure of the Clinton attempts set back things quite a bit, and it was all a horrible. It was a horrible debate. I don't know if you remember it or not, but I do. Yeah, yeah, yep, yeah. And in the military, you had reasonable care for sure. So what happens in the development of healthcare is, of course, there are interest groups. Those are obviously the government is one, but nonetheless, the private healthcare industry and medical associations always and their lobbying groups always seeking to protect them. Anytime you get a tax-funded proposal, the lobbyists come out of the woodworks and do one of two things. They either try to kill it or they try to take advantage of it, skew it in their direction. And the number of different interest groups is you can sit and probably list them all day long. Labor unions and workers groups and insurers and pharmaceutical companies and medical device manufacturers, and just the list goes on. Various physicians groups, various other professional groups, not the nursing associations, the physical therapy association, chiropractors, all of the others. And then there's always in the background the alternative medicine people who are trying to get themselves taken seriously, with good reason. As I said before, the American Medical Association was established just before the Civil War. The idea was to really find a better way to do medical education. Medical education was pretty haphazard. There were medical schools, but medical education was not standardized. So, you didn't know what you were going to get when you had a doctor, hang up his shingle. You didn't even know if he was real. So the AMA was there to do that. They currently have less than 20% of physicians are actually members. There's a lot of people just won't join it. It costs money and they don't see a purpose to it. They have always supported or been opposed to any form of government control, and they've always wanted the government not to have much to say about how medicine is practiced or how it's paid for. However, they had some rough goes. They had some rough times especially when they got kind of beaten up during the debate over the Clinton healthcare initiative, because they were opposed to it. A lot of people really were angry with them. They had they had trouble with their support of Medicare Part D, which was not a great law, but it was one it was the law that was passed under the George W. Bush administration. But they did support the Affordable Health Care Act. They have recognized that cost is a problem, and at some point the system collapses. So if you're part of that system and the system collapses, well, guess what? There goes your income. They saw it happen in 1929 already. With the Great Depression, they watched doctors and hospitals go out of business. Malpractice reform is something that they've been after. They have some victories here. Colorado, for instance, has a limit on the size of any malpractice settlement, to the point that many lawyers in Colorado will not take a malpractice case. They can't make enough money. Yeah. There's a $250,000 cap. Yeah. I think there are some special circumstances where
Was they involved there?
I'm not sure of the special circumstance. If you can show incompetence or, something like that, you may be able to get a higher payment. But if it is just malpractice because things went bad, there's a limit. And so, as I say, a lot of times lawyers will not get involved in that because they can't make, it's not worth their time, which is a shame because, of course, someone's been injured. You can usually find a lawyer, but you may not get one that's really good. But they understand cost containment, but of course they want everybody else to have their costs contained. And so there's a lot of infighting going on. There's a lot of contention about that. Insurance companies have a lot of have a big stake in the way the system works. They have a stake in containing costs, but again, it's other people's costs, not theirs. They want to limit what they have to pay out while they maximize the money they take in. And in fact, they were a big part of what killed the Clinton plan. They opposed parts of the ACA, especially the part where they were going to have to be insurance available to, people that previously the insurance companies wouldn't touch, and it had to be affordable. So that's why we ended up with the individual mandate, so that the people would be forced into the system who could pay, reduced premiums for sure. But if you're a person who's healthy, never gets sick, then your premium is money that you're throwing away. I mean, that's the attitude people have. And they always figure, well, I'll get insurance when I start getting sick. Well, that sometimes isn't so easy either. For years here in this state, when we didn't have access to any sort of corporate plan for insurance, we got independent insurance, but we are healthy. We're never sick, almost never. We don't consume drugs, smoking, drinking, we don't do any of that. Low risk. So we could get a low cost insurance. And then when we went on Medicare, what you do is with Medicare is you have to buy, Part A is automatic. It's the hospitalization. You've paid for that. Part A is automatic. But the Part B is you buy, and that's a premium you pay to the government, and it's a small premium relatively. It's B covers doctor's visits, nursing home, that sort of thing. Okay, so B covers that. It's something that you really are encouraged to get, because if you don't, nothing happens to you until you actually try to get it later on. Get it when you're 65. When you go on to Medicare, and you and if you don't get it then when you do get it, you have to pay a penalty. So they sort of force you into it. And then when you go on Social Security, they'll automatically take it out of your Social Security payment. So, basically you never see it. But the end result is that people will often, but Medicare covers 80%. So the other 20% theoretically comes out of pocket. So what most of us do is we'll get a supplemental insurance. It's called Medicare Advantage, Medicare C. It's called various different kinds of names. But it's basically a supplemental insurance that often will now include Medicare Part D as well. When I first went on Medicare as a healthy person, I could get that plan for a 0 premium.
Really?
Yep. That one, and that lasted 2 years, and then they dropped that plan. So I changed insurers, and I stayed at 0 for another year, but I pay like $27 a month. Yeah. That's exactly right.
Right.
That's exactly right. And it's the advantage to being basically a healthy person and not having a lot of risk factors. My biggest risk factor probably is my weight.
Yeah.
But I am overweight for my size, for my height. Not much.
Yeah.
No, I'm not fat. You know, I'm fat. My brother-in-law, when he died, was this big around. Yeah. It was a shame. He let him, I'm sure it was. It really was because he had a number of things going wrong, diabetes among them, and he'd had a couple of rounds of cancer, which probably wasn't related to his weight, but might have been related to his diet, which was a contributor to his weight. But his weight actually was wrecking his back, and he was in extreme pain. And that, he was 74. 74. As far as we're concerned, too young. Yeah, that's too young these days. Used to be, we thought, oh, you lived to 74, that's good. Yeah, not anymore. Not anymore, it's too young. And I'm 71, and I'm planning to be around a while. My dad's 101. I don't know if I'll make it that far, but he did. But, well, I intend to be around a while.
He was born in 1941.
So another factor here that's changing medical care is consumer groups. Two things going on. There's lots of consumer groups that advocate for diseases and for for care for various people. There's AARP. There's something called the Patients Coalition, which is a whole lot of different organizations banded together as a lobbying effort. There are all sorts of things that people are involved in. And one thing that they get out of it that's really good is people now are more aware that they can get health information. The bad part of that is they go off and they read this stuff and they believe every word they read, and a lot of it's just bunk. A lot of it's just bunk. I read something recently. I went to a seminar recently. It was supposed to be using foods as natural cures for disease. Okay? Well, that's pretty ancient. Been around for 10,000 years as an idea. But this woman started making statements, and one statement she said, eating 1 egg is like smoking 5 cigarettes a day. Yeah, I said to myself, I just scratched you off the list of believable.
Yeah.
And I could not believe it when she said that. I was sitting there and I said to myself, where is that coming from? And the woman looked next to me at this seminar, looked at me like I was some sort of monster.
Oh, really?
Yeah, she was believing every word of it. And I'm sitting there saying, 1 egg? I've been eating, you're telling me 1 egg is 5 cigarettes a day. I've been eating probably 4 or 5 eggs a week all my life. You're telling me now I'm 20 cigarettes a day and I don't smoke? Sorry.
No. That's another
Yep, not going there. And of course, business. We've gone back and forth. When I first started working in the mid 70s, after I got out of grad school, got out of the Army, got out of grad school, every employer had a health insurance plan, and only the very smallest employers didn't. and then they could usually join some sort of group,
Right.
and get something for their employees. So health insurance was considered normal. It's expensive. It's gotten very expensive. And so a lot of employers started cutting back on their insurance, and a lot of insurance business groups started fighting new laws. And now we've seen that now businesses, if they have more than X number of employees that work more than 32 hours a week, they have to give them benefits.
Yeah.
So now we're seeing people who can't get jobs that'll employ them for more than about 30 hours a week, so that the employer doesn't have to give insurance. So this was a problem as well. Not that every company is like that. I mean, there are many companies that recognize that, they need a healthy employee, so they'll provide some form of insurance, but it's there. Labor unions, obviously, they push for these things. And of course, the labor unions, part of their contracts, when labor unions still had the ability to have contracts, and they still, quite a few people are unionized. And the a lot of them, as part of their union contracts, they provide the insurance to the members of their union. So the contractor, the organizations that they work for, pay the union, and then the union takes care of that. And that too. The unions, however, are losing. And possibly the most influential is pharmaceutical industry.
Yeah.
They are gaining from tremendous amount of sales, because, of course, with an aging population, more drugs are selling, and drugs are the mantra. Doctors are trained to use drugs to treat disease rather than look at underlying causes and try to get people to change their lifestyle to help take care of disease. Yep, that's exactly right. So they were able to, when Medicare Part D went in place, they were able to make sure that the law prohibited Medicare from negotiating lower prices for drugs. So the VA does it all the time. The VA's been doing it for years. They get a volume discount on drugs, but Medicare can't do that, which is one of the reasons that our costs are so high. Other countries restrict the price of drugs. It doesn't stop the drug companies from selling. Stand up. It's sitting all day. It doesn't stop the drug companies from selling. France, for instance, has a two-tier approval system for drugs. One is the same as ours, safety and efficacy.
Right.
So it's approved for use. And the second tier is since the French government is the single payer for medical care, they then will set their reimbursement price, which in effect is price control. But they set a reimbursement price. That reimbursement price actually is calculated to give a reasonable profit. They take into account what it costs to develop a drug, what it costs to manufacture it, what it costs to distribute it, and they raise the price to give a reasonable profit. Drug companies still sell drugs in France. In fact, a couple of the largest drug companies in the world are French. So, they don't have any trouble selling there. But here in the United States, we have no such no such system. We don't have a single payer, except for Medicare, for the elderly, and they're not allowed to negotiate. So one of the reasons that we have such high prices is because we have this open capitalist model. And irrespective of your belief in what economic system is good or bad, that's reality. Drug companies are allowed to charge what they want. There are some times when they get a backlash. There's a guy that was put in jail. I don't know if he's out yet for price gouging.
Really?
Yeah, he bought up an old drug that a company was off patent and wasn't selling much, and it had a couple of uses. So he bought it up, repackaged it, renamed it, and jacked the price enormously.
Really?
Yeah, jacked the price hundreds of times. So pills that were costing people $1 a piece suddenly were costing people like $100.
What?
So he ended up actually going to jail.
Good.
But I think he actually got sprung out. So, so then we have the issue of public health. We spend very, very little of our $3.2 trillion a year on public health, and yet public health is these organizations will and agencies start looking at serving several different functions. One is, promotion of wellness for health itself. Another is for prevention of disease, but more importantly, serving the needs of underserved populations, rural populations, the needy, the poor, etc. The fact is, we just don't spend that kind of money. We just don't spend the money on those kinds of services, which is really not very helpful. Yep, economic influences of rising costs. So our growth in spending is rising, has been. It slowed down a little bit recently because it was really rising a lot faster than the inflation in the broader economy, and in terms of growth. These costs are prompting people now to look at how they can cut the costs. The problem is we're not taking a broad sort of unified view of looking at the way medicine is practiced. There is no reason, for instance, for a CT scan in Detroit to cost $1,500 when that same CT scan can be done across the river in Windsor, Canada for $250. There's just really no rationale for that. And uninsured, and the cost of especially health insurance premiums we're at the point where we had an incredible number of people who have no insurance or had no insurance until we had the ACA.
Yeah, my cousin.
Yeah.
He had throat cancer.
Mm.
He had no insurance. He signed up on that.
Yeah, I had a student when I taught healthcare economics several months ago. I had a student who talked about having had breast cancer, and if she hadn't had if it weren't for the ACA, she couldn't have treated him. And I'm looking at it and said, she's a mother, she has fairly young children. I'm sitting there saying, yeah, there's something wrong with this picture.
Yeah.
Something very wrong with this picture. So, and there's lots of reasons that people might not have insurance. it's hard to afford.
Well, you know,
If you're healthy, and before we had all this other stuff, before I had Medicare, I mean, I was healthy. We didn't have health insurance because of our employment status. But we were healthy, so we could get very high deductible policies for an affordable price, a lot more than I'm actually paying for Medicare. But still, we looked at it and said, well, we can afford it. We're going to afford it. So my wife and I both were on that until we both went on to Medicare. And now we have, we're paying more than we need to pay because we're so bloody healthy.
yeah.
But nonetheless, we aren't. Pardon? Yeah.
You pay more if you got
Yeah. But we, there we are. You've studied HIPAA. I know in your billing and coding classes. I know you studied HIPAA. You probably wrote a bunch of papers on HIPAA. So we don't need to go into that. But the purpose with HIPAA was really to make sure that if you change jobs, that you could transfer your coverage, and that your records could be transferred as well. Doctors couldn't just refuse. Most of them wouldn't have anyway. But we had also we've always had the issue of pre-existing conditions, which is what the ACA is probably one of the biggest things that ACA did that helped people was the restriction on the ability to deny coverage for pre-existing conditions. That became it was very costly. If you can't get insurance for it and you still have the disease, either you die or the public pays for it. So, the problem is for-profit medicine. So, and that we've mandated medical records, electronic health records now. That was fought tooth and nail. I mean, I used to hear yearly, well, in October of this year, we're going to be, everybody has to convert. And then, well, October of next year. And then October of next year, they kept pushing it out because physicians couldn't afford it. And there was no national agreement on how this was going to be done. There's lots of vendors that sell health record software. Okay. Then, of course, there's the aging of America. One of the biggest things that happened was the movement toward the disparaging term is physician-assisted suicide, but the death with dignity issue. We saw that this last election here in Colorado, and as far as I know, that got knocked down. But there are a number of states that now are allowing it or are contemplating allowing people to end their own lives with very stringent guidelines for how that can be applied to prevent any form of abuse, because you can see that such a thing might be prone to abuse, but we've always had a form of that with things like advance directives. My mother-in-law, for instance, whenever she's been in the hospital a couple of times recently, one of the questions they'll ask is, if you have a heart attack, do you want to be resuscitated? And she had been talked to one time by one of our physicians, said, look, at your age, They're going to break your ribs. You only have about a 5% chance of coming through it.
She always says she wants to.
Oh, no. She says absolutely not. But, after this doctor said, this is what could happen to you if we start doing CPR. You'll have broken ribs.
Yeah.
You'll be in extreme pain, and there's only a 5% chance that it'll work on you. And she said, why would I put myself through that? So she always says no. Now, the problem is there's a book probably I think people should read. It's called Knocking on Heaven's Door. Sounds like an Eric Clapton song. But Knocking on Heaven's Door, and it's written by a reporter by the name of Katie Butler, and it's about her experience with her father, a very highly educated professor who developed Alzheimer's, and they stuck him onto a pacemaker. Pacemakers keep you alive. Used to be that you get up to a certain age, your heart starts not working, you just die. But a pacemaker keeps your heart going. You can still die, but your body's still functioning, and it keeps going because the batteries last 10 to 12 years. Okay. And many, even with all sorts of knowledge about what's going on, in the case of her father, he was comatose apparently, and he had an advance directive, and the hospital would not turn off his pacemaker, which they can do. They don't even have to take it out. There's a little device they can put over it, and it'll shut it off. But they won't do it. My sister, I had two younger sisters. There were three of us in my family, and the middle child, the older of my two younger sisters, died a year ago, almost to the day.
Really?
And we found out she was in Texas, and she'd been estranged from the family for a long time. But we found out that she had not only a pacemaker, but an implanted defibrillator. So she had severe heart disease, and her problem was lifestyle, but that's neither here nor there. But she died last year. That would have been 2017. She was born in 48, so 52, 69. She was approaching. She died, I think, the day before her 69th birthday. Yeah. And she had this implanted defibrillator, and her brain had no activity. She was comatose, and there was no cerebral activity. They would not turn off the pacemaker. They could turn off the defibrillator, but what they told my niece was that it's illegal to turn off the defibrillator. And I looked at my niece and I said, that's a lie. It is not. They just don't want to. It is not illegal. Then 2 days later, she passed anyway. But, we had just read the book by Katie Butler at that point, and we're sitting there saying, maybe this is why we read that book.
Yeah, exactly. Synchronicity.
Yeah. So, but it was really kind of a shock. Two of my younger sisters, and I expect to outlive them both. Anyway, let's take a break. I'm going to pause. Okay, let's get started again. So this changed the lay of the land, these death with dignity regulations. Okay. And of course, the internet has changed the world quite a bit. with things like smartphone apps,
Mhm.
and being able to go in and look up information, which has led to problems. Some of the information on the internet is not good. It really is not well regulated, and people can say what they want. But one of the nice things is you can get ratings on institutions and doctors and
Mhm.
other
And that's
things.
what I do.
Yeah.
In fact, I made a couple of doctors today for reading her reviews, and then after I read the reviews, I called them.
Yeah.
I'm like, no, thank you.
Yeah. You should. We still talk to our nursing friends about who we should use.
Oh, really?
Mhm.
Wow.
And we figure they know the ones that are good, but they also know the ones that they wouldn't go to. That being the case, we don't either.
Yep.
So then we have the ACA, which was one of Obama's campaign pledges, and he kept it. There were many challenges to the ACA. Depending on what court it was in, the ACA was either ruled fully constitutional, fully unconstitutional, or partially constitutional.
Mhm.
So of course it had to go much higher. And it was ultimately basically partially supported by the Supreme Court. The individual mandate was upheld. That was one of the biggest problems that people had. But the expansion of Medicaid was left basically up to the states. The implementation timeline was a 10-year period, 2010 to 2019, to try and bring it in. Because the way laws are done in this country, Congress passes a statute, and then a federal agency has to figure out how that statute is going to be applied. And so they come up with the administrative rules, which is effectively administrative law as to how they're going to do so. And that's real common. When the FDA was created, the FDA was told that drugs had to be shown to be safe and effective. Congress wisely left that up to the experts to figure out what safe and effective meant. And they worked out rules. And those rules evolved as problems arose. Same when the Environmental Protection Agency was put in place, the Clean Water Act, clean up the water. Well, the EPA was left to figure out what that meant in terms of regulations. And people challenged regulations. Some of them got knocked down, some of them didn't. But that's how that worked out. So we had ability now. When I was still getting insurance, which I was doing for, when ACA passed, the person I worked with, insurance, would have me go online and print out the available policies and then make a choice. And then he'd write up the paperwork. So I could do that. And it allowed me to really just look for my insurance. And of course, I didn't have to worry about things like pre-existing conditions. You got to have any. But lots of other things were put into place to protect consumers and to help employers. Small business tax credits were given. Sometimes rebates were given. Um, um, Free preventive services. So that's why now when you go on Medicare, they start nagging you to come in for your free checkup. Well, the free checkup isn't really a checkup. But you can usually at least see a doctor. So lots of changes were put together, and there were lots and lots of different parts of the law which you'll study when you're working on your LRA. So we're working to try and we were working to try and make this work. And then last year, of course, we had all that kerfuffle at the end of the year about trying to get rid of it.
Right.
And the interesting thing was how many of the governors of the states were opposed to their own party's plan, because they looked at it at the cost that it was going to cost their states and realized that they couldn't change it. So we also looked at quality of service. We also started looking at outcomes. Something that had been talked about for a long time was outcomes. Why should somebody be paid for something that, you should be paid for services, but you should also be watched for the outcomes. Now, outcomes in medicine are difficult to measure because every patient's different. And patients, you can treat a patient very successfully, and then the patient dies anyway. So what does that mean? It's a very confusing issue. Anthony? Pat was looking for you with one of his students. Did they find you? Pat? Yeah, they were. No, they didn't know. They were down here looking for you. So, I don't know. He was looking for you just around break time. So you might want to look in on his class. You bet. So we, the idea was to increase access to care. That one of the nice things was that young adults could be insured on their parents' policies now up to age 26.
Yeah,
Helped my daughter a lot.
my son too, before he went into the military.
Yeah.
And he's at the mercy of the VA.
Yeah. Well, fortunately, I haven't had to worry about that yet. So the idea was to really try to make sure that more people got health coverage. And the theory, of course, was that the more people have health coverage that's covered by insurance and other forms, then they're less likely to seek help through expensive emergency services, and the costs should go down.
Yeah.
I'm not sure we've seen that. But we also offered scholarships and so forth, and reductions in loans to people willing to work in rural areas. And that's been around a while, but that got expanded. And I can remember knowing some medical people who wanted to have their medical school debts erased, and so they would go and work in rural, Appalachia, and they would find that the people living there were wonderful people, and they'd end up staying, having no intention before they went in. Obviously not everyone, but it had that the idea of trying to get people to move into underserved areas was a good one, and it helped a lot of people. To that effect,
Got a couple more hands. One is a middle of last year, an analysis of the issue of affordability. That's been something that's been coming up in the medical literature a lot, is the whole idea of affordability. The whole idea with the ACA was affordable health care.
Well, you know, I saw it maybe sometime last year, and it was interviewing this guy. He had a family. He was a middle class white collar. And he was pissed off at it because he had to pay like what, $800 a month. That's ridiculous.
Mm-hmm. It was, again, one of the unintended consequences was that certain people saw their health care insurance go up because of their income level and because of what they were covering, their coverage. And the whole process was kind of convoluted. But when they changed, in order to get 30 extra million people onto the rolls, somebody actually ended up paying more. And that should have been anticipated, in my opinion, should have been dealt with. On the other hand, it wasn't breaking their backs to pay that money. It was annoying. Yes, I won't argue with that. $800 a month is a lot. We have cousins down in Littleton, and they pay $2,500 a month.
What?
Yeah, that's what he told me the other day. I was sort of, wow. And another article here is really a look. This comes from the Commonwealth Fund, which is an independent, sort of non-denominational, if you will, nonpartisan research fund about listening to low-income patients. And we got them all over the nation. And one last thing I'd like to give you is something I downloaded and was absolutely stunned. Turned out to be 311 pages. Well, it was about it was from a website called Health Markets, and it was about healthcare reform news. And it was updates, and they took their updates all the way back to God knows when. So I printed off about 30 pages of the more recent stuff. The latest one on here right now is a week old, but it is it is about what's going on with healthcare reform news in this nation, and it's got some interesting little blurb. They're just blurbs about what is the current activity. There is very little in the way of analysis, but the first thing we hear is what's going on, and so we want to know what that. So lots of other issues were put into the ACA to try and make healthcare affordable, including some accountability issues for health insurance companies. Yeah, what are you doing with the money? And so basically, they want to be sure that those premiums are being used for treating healthcare, for providing healthcare services. The premiums that, especially for employers, the health insurance companies are different. They pay money the same way that the government for Medicare and Medicaid pays money for medical services. You bill them, they send you a check. There is the cost of operating the organization. The cost of operating the organization
should be pretty much limited to essentially paying for the space you occupy to run your business and paying the salaries of the people that are doing the work. That's called the overhead. Medicare runs about a 6% overhead. About 6% of our Medicare dollars are actually spent on the operation of Medicare. They paying the costs of the facilities and paying the people who actually do the work. For insurance companies, it has been as high as 25%. This is one of the biggest things. You see these insurance executives with multi-million-dollar salaries, whereas you've got a guy at GS, 14 at CMS who's taking care of this, making $120,000 a year. There's a big difference there. So, we have a lot of those things. So we have, and it costs money. Costs money. There's no free lunch anywhere in the world of medicine or anything else. But if the government, the purpose of government is to provide services for the citizenry, and if we have just insured 32 million extra people, well, that's a service. It's going to cost money. So that's basically that history. We're going to jump now to, I'm going to do a new share, and we're going to jump to I'm looking for, nope, different. So I'm going to stop that. I'm going to, and then we're going to do a new share, and it's going to be there, chapter 6. We're going to look at medical education and changing practice and try to get through this quickly. We're just very, very briefly, in colonial times and pre-colonial times in Europe, up until about the middle to late 19th century, we had no medical schools. We had people who would use medicinal herbs and other kinds of approaches in their homes. We had a few physicians who'd been trained in Europe, and they basically trained other people to be physicians as apprentices, who would then go on to become physicians and then train the next. It was like a guild. There was no testing. There was no regulation. You probably did just as well by going down to, to the local healer, and got your treatments there. This is what was done extensively for many centuries. Medical schools, hospitals began to appear. Ben Franklin is famous for having established the first U.S. hospital. That may or may not be the absolute truth, but it was an early hospital for sure. The first of the medical schools appeared in the middle of the 18th century. Yep, at the College of Philadelphia, and then at what is now Columbia. But by 1800, there were only a few medical schools, and then we started seeing some of the states restricting, putting in rules for medical graduates. And this all grows out of the fact that under our constitutional system, the states have the right to regulate professionals. and medical people were considered professionals. So to this day, doctors are licensed by a state. They can get that licensure recognized by reciprocity with other states, and that applies to all of them. My wife got her first PT license in North Carolina and practiced PT there for 20 years before we moved back to Colorado. Colorado accepted the fact that she had been licensed and maintained her license in North Carolina and had been practicing for 20 years, and they automatically licensed her. And each year, all she has to do now is show that she has done her continuing ed, and the licensure is automatically renewed. Theoretically, she could practice in other states, but she would have to get that that licensure by reciprocity. There's a few states that don't do that. But doctors, lawyers, medical medical professionals like nurses and therapists and so forth are all regulated at the state level. We have very few national certifications. Fortunately, the certifications we get through NCCT and others that you take here, these are national certifications. And some of the medical board certifications, like if you are certified by the Board of Physicians and Surgeons, that transfers. That's a national certification. But your actual license to practice is governed at the state level. So we started seeing medical societies and changes in education starting to appear in the 1800s. Then we started to see that we were getting what is looking more like our modern medical education by the end of the 19th century. We were starting to see that. Lots of other things developed. There was lots of training schools. There were lots of money from the Carnegie Foundation was given to a lot of medical schools. So there was the AMA, which established reforms for medical education, started being followed by the schools, hoping that they would get support from the Carnegie Foundation. There were several reports. Some really were kind of critical of many of the schools, but also very complimentary toward others. We kept changing things. We started having a shortage of hospitals during the Depression because they went out of business. And then in the middle of the 1940s, we realized that we had a lot of people coming back who were going from World War II who were going to need medical care. And so we funded hospitals. We started looking at a variety of different systems to integrate medical training with medical research and general health. And so we started seeing the big university-affiliated medical schools, such as we have at UCH down in Denver, such as we had at the North Carolina medical schools in where we lived in North Carolina, Duke Regional Center, and so forth. All these things were to actually broaden their training to include not just physicians, but also dentists, podiatrists, pharmacists, nurses, and all sorts of other people. They really became primary sites of medical training. They really provide, many of these provide some of the most advanced care, some of the more difficult care. When our second child was born, we were living in Durham, North Carolina. We had Duke University Medical Center. We also had the county hospital, which was a reasonably good facility, but the only neonatal ICU was at Duke. And so our baby spent the first couple of days of her life in ICU at Duke. They also had a burn center. My wife used to work with patients treated there when she worked at the VA hospital, which was right across the street from the Duke University Hospital. She used to deal with that. Lots of advanced work for these physicians in training. Good stuff. But then we started seeing the expansion of medical schools and associations to try and improve the quality of education and governance, and make sure that when you got your MD degree from Wake Forest University Medical School, that your training was at a level that would match that of the premier institution in the state, which was the University of North Carolina at Chapel Hill. And we had medical schools all over the state. But again, all of these things are really regulated at the state level. Graduate medical training basically goes past getting to your MD degree. You get further training. The idea is to look at areas that with the ACA was looking at how can we address the coming problems in medicine. The appearance of medical specialties, meaning things like ophthalmology, pediatrics and stuff, began to appear in the 19th century. The AMA was concerned about very fragmented care, that here you are, your specialty might be ophthalmology, but you had an MD degree. And so are you capable of treating a fracture? Well, you've been trained, because ophthalmologists go through medical school and take all those classes. But it was sort of like when our first baby was born, Susan and I are RH incompatible. So she had to get a RhoGAM shot.
Really?
Yeah. She had to get a RhoGAM shot. And so we're waiting for that. And in comes this physician. And he looked nervous as a bunny. And Susan looked at him and said, when was the last time you gave anyone a shot? And he said, medical school.
Oh my gosh. I would have said, go get somebody else.
She rolled over and said, do your best. Because we'd waited quite a while to get him there. But what we had is that we had people that would call themselves specialists, but they wouldn't have any particular training. And it actually took World War I to realize that we had an awful lot of quacks in the medical, passing themselves off as experts. They'd been through medical school, they'd had general courses, and they'd passed themselves off as cardiologists. Very. Actually, the Army, when they were recruiting doctors to send over to Europe for World War I, they found out that they had an amazing number of people who were actually unfit to serve. So we started looking at how we can really change the medical education and make sure that these people were properly trained. If you said you were a cardiologist, you had to be vetted by the American, College of Cardiology. We changed the way we did internships to get people trained up, and that curriculum for specialization. And Why do people want to be specialists? They make more money. You know, when you meet somebody who wants to be a generalist, you almost ought to say, God bless you, you know. But the current is they have to graduate from medical school, so they have to have a general medical education, and then they have to go to a residency program approved for that specialty, and then they have to get through that program and pass the qualifying exams. And the qualifying exams are not easy. So a fair number of them flunk the first time around. Okay. So we have we've had most of the time doctors didn't work directly for hospitals. No, they'd have their own jobs. They'd have hospital privileges. They could admit patients into a hospital. They could practice medicine at the hospital, but they had to have privileges at the hospital. Now there's a growing field called hospitalist. And I just heard that term used a few years ago when we had a time when my mother-in-law was in the hospital. I heard that term and I said, what in the world is a hospitalist? And that is a physician who actually works for the hospital. Most of them are internal medicine and or peds specialists, but they can also be, you know, have specialties in other areas. They really are now quite a few of them practicing. So they're salaried people. So they come in and they have a role. We go up and down on our supply of physicians. And right now, the median, at least when this book was published in the data from about 2014, about 244 physicians for every 100,000 people in the population. Now, that means that there is about one for every 4,000 people. To put that in maybe a little more. Yeah. Don't. We have the problem is we have no way of looking at the issue of supply and demand. You know, a healthier society should need fewer physicians, but we don't have a healthier society yet. Do we want a bunch of people to go into medicine that maybe they won't be able to get jobs in 15 years? Yeah. So, and there's wide variations. There in terms of the number of physicians for the population as well. That's an average. That 244 per 100,000 is an average. So we have a shortfall of graduates in the U.S., about 6,000 a year. Fewer graduates that are U.S. citizens than we need to maintain a supply. So what are we doing? We're filling them with international medical graduates. They're well trained, but now with an assault on immigration, we don't know what that's going to mean. That's going to be one of the fallouts, I predict. We are finding that fewer people want to be family medicine specialists. Yeah, because they don't make as much money and they have to work god awful hard.
Really?
You got to see, family practice, general primary care physicians, what we call the PCPs. They're, they go into the specialties because they can make more money. When you meet someone who wants to be a primary care physician, then again, you really want to be happy to hear that. In a study in the an organization for family medicine in 2012, we'd need 52,000 more primary medical physicians by 2025. 33,000 of them just for population growth. 10,000 more for aging, population, and then 8,000 more to cover newly insured people. Right now, the 2/3 of physicians are specialists.
2/3?
2/3. Yeah, the ratio is 67 to 33. So 67%. Okay, this is, now, do we need specialists? Absolutely.
Yeah.
Medicine is too complex. But we also need the generalists. Okay. So medicine is going to be one of the most rapidly, is one of the most rapidly growing areas of employment at all levels. We need people, not just MDs, we need nurses like crazy, we need therapists, we need phlebotomists, we need pharmacy techs, we need pharmacists, we need people who can handle billing and coding, people who can manage the offices. We need all of that just to be able to stay with need. So we're going to see we're going to see some changes. As I said before, physicians were usually just associated with hospitals. They'd have practice privileges and stuff. The problem with that, of course, is that then they're not out there seeing private patients there, and so we have more of them going into the hospital. Hospitals want it because they want they want to have people in there so they can increase their market share. There's for-profit medicine it has a lot of problems associated with it, and there are lots of issues with issues of the financial incentives that they may have to treatment options. Because as I said before, I was real surprised when the guy told me that he didn't think he should operate on my shoulder because it wouldn't help. I mean, it was to his advantage to say, well, we'll operate on your shoulder and we'll fix it or try, and put me through a lot of pain for nothing. Or he could be honest and say, I can't help you. You got my vote, Next time somebody wants to see an orthopedic surgeon, guess where I'm sending them?
Exactly.
So, we have to do that. We've changed to trying to get people to look more and more at the patient and look at the evidence for the patient for looking at our practice guidelines. Problem is there are so many guidelines. It's just really ridiculous. So there are physician report cards and compares. We'll talk about health information technology next week, because that's really coming into to an important state. And we're looking at malpractice insurance. Malpractice insurance has just been skyrocketing for everyone. Physicians, hospitals, even medical schools. We're looking at I remember back when our daughters are 30 and 33. And when our first child was born, or when our first child was born, I think the malpractice insurance at our group practice was $14,000 a year. They got out of OB after that because it was going to skyrocket from there. So, this just is it's a killer. And this is why there's a large group of people who believe that we need tort reform in this nation, because the lawyers are out of control. Well, guess who's going to pass the laws about tort reform? Lawyers. There are people in Congress. So we have, there's all sorts of ethical issues. You've studied healthcare ethics, and so we won't go into that too much. We're starting to look through various changes in the way physicians get information. There's so much information that one of the challenges to being a physician is how do you get information about new treatments, new things that you need to know. So medical schools will probably see some changing, and they're looking at how they can educate these doctors even better, because it's a difficult task. When I was down in Denver, I used to take students a couple of times a year to a cadaver lab, and so that they could basically play with a body, and they were generally run by medical students. And the first couple of times we had the same young man that was the medical student who was running the cadaver lab. It was a 4-hour lab. We'd spend an entire evening at Lutheran Hospital in Wheat Ridge, and it was real interesting. But we had he was saying at that time he was a third-year medical student. He'd already accumulated $235,000 in debt. And he
Oh my God.
wasn't particularly clear how he was going to pay it off. So,
Be in debt for them.
yep, I'm afraid so. So let's look at moving on to now
Okay.
chapter 7 of your text. Here we go. And this is sort of the workforce. So we'll go through this. The workforce, it's one of the largest U.S. employers, probably exceeded by the government. But probably 17 million employees. By now, it's at least that. Occupations and professions, over 200 different medical professions and occupations, and that ranges all the way from medical billing specialists to to neurosurgeons. Hospitals are major employers with respect to everyone except physicians, as we talked about before. Although hospitalists are appearing, we're seeing in the next couple of years we expect another 2 million jobs. What they're saying here is over 5.5 million new jobs in the next decade. So it's possibly the fastest growing area of employment that we have. But it is growing in a lot of different areas. Ambulatory clinics are popping up everywhere. Home health, there are, I don't know how many. Several years ago, there were over 100 different home health agencies in the Denver area. I don't know how many there are now. Practitioners' offices all over the place, although they're consolidating. And moving into specialty areas. I told you about trying to get a prescription for one of my mother-in-law's blood pressure medications approved for refill by her primary care physician, who said, I can't do that, it has to be the cardiologist. No, that's not good. That's not good. Blood pressure is something that used to be treated by the local physician, and now we have to send them to a cardiologist. Just not a good idea. So the issue is that we want to protect our patients from incompetent practitioners or unethical ones. How do we do that? Well, we do that by regulating the profession, and it's primarily done by the state, as we said. The methods are state licensure, which everyone gets, certification, which The allied health professionals like phlebotomists and medical assistants and so forth will get. Yep, all those transcriptionists and so forth. And then we have just registration of people with the proper timing. There are issues. Healthcare is changing so rapidly that we need to look at our methods of credentialing. State licensure is usually through some sort of board. In this case, we have the medical board that's part of the Department of Regulatory Agencies in Colorado, DORA. And they have a nursing board, and they have a board for pharmacy, and they have a board for medical assisting and so forth that look and establish the requirements, the educational requirements, and the scope of practice, what they can do. Because we want to be sure that the people who are doing this are doing what they're trained to do. And the problem in the medical profession has been that we often will be pushing people who are not properly trained to do things that they shouldn't be doing to save money. And that's part of the problem. We've seen that. I've seen people get into a lot of trouble for that. The use of titles, it is absolutely unethical if you are a medical assistant to allow a patient to call you doctor or nurse. It's actually unethical. Yeah, it's unethical to do that. And it's probably illegal in some places, but because people will, you walk in, you're wearing scrubs, you take blood pressure, you take a history. Some people are going to call you nurse or doctor or whatever. You really should discourage that. I'm not a doctor. I am the medical assistant. The doctor, I'm just getting information for the doctor. Doctor will be in shortly. Or it might be the physician's assistant or the nurse practitioner. But the person that you can talk to. And then when the PA comes in, they shouldn't be called doctor either. They should not encourage that. It's one of the questions that we have in one of our classes. I think it's our ethics class. That we talk about. There's little that we do to require continuing competency testing in any of these fields. We only require that they take continuing education courses.
Oh, you do have.
Well, teachers are a little different. Yeah, it's a different controlling organization. The medical profession gets jealous about regulators telling them how to do their business. Okay, but that is one of the things. Getting someone to lose their license to practice is a very difficult, complicated, almost impossible process. Yeah, they really have to do something really, really awful. Yeah. It really is something to be concerned about. But yeah, let's see. I don't guess anybody else is coming in tonight. Little late. I'm surprised Amanda's not here. There's almost, unless someone is actually doing something totally illegal, you almost can't force them out of practice. You can revoke certification, in which case then it's illegal for them to practice that field, but there's not a whole lot we can do. And doctors protect each other.
Oh yeah.
Some of them have, not some, there are a number that will not cover for incompetence. And especially if there's been some real harm. Errors, everybody makes errors. what you don't like to see is a pattern.
A pattern.
You know, everybody makes mistakes. So, you know, you can't just, oh, well, you screwed up this time, therefore you're out.
Mhm.
Well, you know, if that were the case, the surgeon who worked on me several years ago and almost, um, as a result of his surgery, they almost lost me because of problems in the surgery, you know, but he came to me highly recommended by my nurse friends as a fine surgeon. And quite frankly, if it hadn't been for emergency medicine developments by the military, I would have died.
Oh my.
You know, am I going to try and get him punished for that? No way. I didn't. I mean, I couldn't show any harm. Inconvenience? Yeah. Being filleted, looking like somebody went after me with a chainsaw? Yeah, that was not too good. But I lived. So, and, you know, who am I to say? He did a better job than I would have. Okay. So there's some statistics in here about physicians and postgraduate training and so forth. Nursing really didn't start up until actually during the Civil War. There were people who functioned as nurses, but the real professional training actually started during the Civil War. And nursing has increased, and what they've been allowed to do. Nurses now are very well trained. Some of them go on to become nurse practitioners, so they can do minor surgical procedures. We have a friend who's a physician's assistant who had started life as an EMT, went to PA school, and ended up working for the State Department in various posts around the world as the medical person in an embassy. He worked under the direction of a regional physician, but he took care of basically minor problems. And then when further work was needed, either they were evacuated off to a proper hospital, or if it was something that could be handled locally, then the physician himself could come in. But you know, so we have people that are quite good at these, and they really high quality care. Go ahead.
One person that I interviewed is my niece.
Mm-hmm.
2 years ago. 3 years ago. She's an LPN. Is LPN qualified?
She maintained her license?
Yes.
Yes, if she's got her license, I'll take that.
Okay.
Yeah. Yeah, well, yeah, I can understand. Nursing training has changed.
Yeah.
Nowadays, you know, basically you can get an associate degree in a couple of years, pass your RN exam, and be a registered nurse. Now, many people are requiring a Bachelor of Science in Nursing degree. So that's a 4-year degree. Many people who get their RNs with a 2-year degree will go on then and earn a BSN. And then they will also move on sometimes and get master's degrees. I have a number of friends who have master's degrees in nursing now, and a couple who have gone on to gotten PhDs.
Head nurse at hospital in Atlanta. She went to school with her. She went on. I couldn't do the medicine thing.
Yeah, well, good for her.
Yeah.
Good for her. Glad to hear it. A lot of, you know, hospitals are the biggest employers. Occasionally you'll see a physician's practice that has a nurse, but usually those are going to be a nurse practitioner. So they'll actually be doing at a higher level. Most nurses actually work in a direct care setting. We have a number of different levels. We talked about that. Most nurses still have gotten their their basic education at a place where they get an ADN and then go on and get an RN. But we're changing that. Many of the programs, the program that we had down in Denver, we had an ADN program down in Denver at College America, and
Oh,
that
really?
we dropped it.
Really?
Yeah, we dropped it. It was too small to be viable. And more people are now looking for BSNs. So, we were not prepared to rise to that level of training. We didn't have the ability to handle it. So, a lot of schools offer doctoral programs. The nurses are in short supply. They are in short supply. You go into a hospital, I can guarantee you're going to get, if you go into a hospital and you're the kind of patient that is independent, that the nurse doesn't have to come into every 2 minutes, they fall in love with you. They do. They fall in love with you. And the 2 times that I've been actually had to have surgery, the next day I was up walking around. And so I'd just look around and unplug the IV pump and start trucking up and down the hall. Nurses loved me. They didn't have to take care of me. They'd have to come in, and do all their other stuff. But, we got along well. And we had quite a good relationship. There are LPNs. They have about a year of training. They're state licensed. They're more and more not being employed by hospitals. They're moving down into nursing homes and residential care. Yeah, some of them are actually quite are still employed. Some hospitals, but it's starting to decrease. The RNs are trying to push them out, to be quite frankly. Yep, they are. And the reason they're doing it is, I shouldn't say the RNs, but they're part of the group that's pushing them out, because they're trying to get the work done that's been done traditionally by LPNs, by CNAs, because CNAs are cheaper. It's all about money. But we still expect to see employment increasing. If your niece has her LPN, tell her, even when she retires, keep her license.
Well, she's going RN now.
Oh, good.
Yeah.
Good for her.
She didn't take a break.
Good for her. Okay. So NPs, nurse practitioners, it's an advanced education. Most of them have master's degrees, but it's an advanced education, and they can specialize in a variety of different specialties. They can do emergency medicine, geriatric and pediatric work. Some of them are employed in neonatal intensive care units. But the programs themselves are pretty rigorous, and it's a national certification. There's a clinical nurse specialist. It's they focus on the sicker patients, and again, it's a highly difficult. It's a rigorous training program. Other medical professions, dentistry, dentists go to medical school. Yep, they take a lot of medical classes, and then they move over into the Doctor of Dental Surgery program. And so their medical training is fairly limited, but they are trained in the variety of the procedures for dentistry, and some of them are very, very good. There are mostly general. There are people that are specialists, people that specialize in certain kinds of periodontic procedures. The dentist we used for years down in Golden would not do a root canal. He would refer somebody out because he didn't feel he was good. His qualifications were good enough to do that properly. You know, he did all of his own work. If you went for a crown, you went in and you came out with the crown that morning. So, and I actually watched him make one of mine. It was really interesting. He had a machine that carved it. It was really kind of cool. Dentistry, we're starting to lose. We're starting to lose some of our dentists. But dentists operate aside from the medical field. You have to have special insurance, so you're not affected by a lot of things. Pharmacy. Pharmacists used to get a bachelor's degree in pharmacy and then get licensed by the state. Now, pharmacy schools take you, after a couple of years of undergrad work, you go into 4 years of grad work to come out with a doctor of pharmacy degree, a PharmD. So now we have PharmDs. Pardon? Yep. They're highly specialized, and of course, there's lots of subspecialties in pharmacy too. Most of them, you know, they're pretty well distributed between, you know, commercial community pharmacies, hospitals, and then other institutions and other locations. They employ technicians to do a lot of the regular work. Podiatry is, again, it's a medical specialty, but it's basically works with the lower leg and feet. They perform surgery, they prescribe drugs, they do tests, but they are specially trained in just dealing with the feet. Okay. Chiropractors, lots of those. They go through a specialized training program. There are several different basic schools of chiropractic thought. So it depends on who you get. Optometrists are not ophthalmologists. Ophthalmologists are MDs. Optometrists do not get involved in surgical procedures, and their ability to prescribe drugs is very, very limited. Okay. Okay, they diagnose problems, and if there is a real problem, they have to send you to an ophthalmologist. So if you need cataract surgery, you go to an optometrist who does an examination on your eyes and says you have cataracts, you need them taken care of, he'll send you to an ophthalmologist. Your area, healthcare administration. We have lots of different levels, BS, MS, and doctoral programs. They're employed in a variety of different areas to basically manage and coordinate the services in those practices. They don't practice medicine, but what they do is they manage and help with managing and coordinating services and others. Then there's our allied health personnel. There are lots of different lab techs. These are the people that do the analyses. We've got rad techs, radiology technicians, nuclear medicine techs. These are very, very well-trained people working with radioactive material, drugs, and imaging. Therapists, they call them therapeutic science practitioners. We got PTs, OTs, language pathologists, speech pathologists, PAs. Again, I know a lot about PT because that's what my wife did for 30 years. They work all over the place. And they work with patients of every single age group. Nowadays, the beginning degree for a PT is a Doctor of Physical Therapy degree. We've got degree inflation going on. OTs are the same. We have a very good friend, a young woman who's basically our third daughter, has just been admitted to an OT PhD program or a Doctor of OT program in Arizona. So again, you really do have to have a master's degree for that. Speech pathologists are well trained. PAs, the whole PA thing started off with what do we do with people that are going to be working as field medics in the military, especially during the Vietnam War. So we had a lot of need for that. So they're well trained. They prescribe drugs. They work independently, but under the supervision of an MD. And we're finding that more and more physician practices will bring in PAs and nurse practitioners to provide much of the direct medical care. Behavioral sciences, social workers, rehab counselors. Then we go into health administration technology. Then we have alternative. The issue with alternative medicine is really an undefined area. Many people, alternative basically means outside the mainstream, and then there's complementary medicine, which is meaning that it adds to the mainstream of
Like
medical
holistic,
care.
right?
Pardon?
Like
Holistic is actually alternative.
Mhm.
Kaiser has a couple of complementary and alternative medicine centers here in Colorado, where they have chiropractors and other other people. They haven't embraced things like homeopathy or naturopathy yet, but they do have a lot of different alternatives. We're starting to understand that traditional medicines work. I told you about the Chinese specialist who came in and just basically physically examined patients and came up with the right diagnosis. And then there's, what are the demands, the factors? Well, increasing population, increasing insurance people, people who are insured. The corporatization. Anyway, the turning these big medical practices and hospitals into large commercial operations means that we need more and more healthcare personnel. One of the things that the ACA was trying to deal with was how do we get more people into the medical field. The future is kind of excuse me, kind of hard to predict, but we don't have any really future thinking, no plan, no national strategy for dealing with our needs for healthcare. And and people aren't addressing it. Simple as that. Okay. So, all right. So let's go back. Okay. If we go back to the course modules, then quiz 1, then the discussion, which is the finances affecting healthcare. You've already done that. The terminology assignment, and you've done the professional. No, you've done the introduce yourself. I think you did. You don't. But that's there as something. The maybe that's in my other class. Yeah, your personal goals. Personal goals. Yeah. So we have a research project progress report due on the weekend. So I will, after this class, I'll convert the Zoom session into a YouTube video and get that posted.
So I guess we're done for today.
I guess so. Hmm.